Alright, revision, Stapes operation, and we have a history of long-term failure. This patient was operated by another surgeon, and there is a history of good initial results, and then suddenly sudden hemogloss many years after. And what we can see here, this is right here, so this is 12 o'clock, 3, 6 and 9. We have this dislocated piston here, which is not anymore connected to the incus. And you can see you have this loop of the piston which is quite open. So I think probably during the previous operation the loop was not closed enough. And then, because you know they're supposed to have a memory, but Teflon has a memory, but we really need to help the memory by closing it. So I'm going to remove the prosthesis now. Which is good news is that we have a normal incus CISO, which is fine. So then we can use an incus to stapedotomy reconstruction, which is always associated with higher success rate than Malleus to stapedotomy. I'm going to check now the Malleus incus mobility, Canley. And we have a nice mobility, so it's good. And now I'm going to go to the oval window, stop, and we will need to re-fenestrate, of course, the labyrinth. Because if we put a prosthesis like this, it will slip away from the oval window. So it is really important to recreate a new fenestra through this previous interposition. It seems that the surgeon was using some interposition, a vein graft, and this is probably the location of the previous fenestra. So I will measure, but not now, because we have a little bit of a lateralization. So I need to reopen this fenestra, and then I will measure only when the fenestra will have been done. Okay, so let's do it now. So I'm using, again, as usual, 0.7 millimeter diameter diamondous burr. And I'm going to drill out this membrane. And you see now it's done. So I can now measure the distance, mesureur. So it was a very thin interposition. So it's quite long, 4.75. You see the 4.51 is lower than the incus. So I will cut the prosthesis at 4.75, 475. Alright, I will put the vein graft now, which I already prepared and pre-shaped. We're facing now the intima of the vein as usual. And I will grab it with the 0.9 millimeter diameter suction tube. Alright, now I'm going to seal now the labyrinth with the vein. So as usual, I'm going to introduce the vein with my left hand and the suction tube, holding it with the suction tube and stretching it with the needle with my right hand, like this, so it's fine. And now we have a nice position of the vein with the previous fenestra, which is there. Okay, and now I can cut the prosthesis at 4.75, a new one. Using the cutting block right here. So again, if some people do not measure and use a 4.5 millimeter long prosthesis, in this case would be too short. So I really believe it is important to measure and adapt the length of the prosthesis accordingly, rather than using always a 4.5. Now, of course, opening the loop of the piston, breaking the memory, but then we need to crimp it again to avoid the same problem post-op as following the previous operation. Alright, so I'm going now to introduce the shaft first within the Fenestra, and then the loop around the Incus, and I will crimp out the loop. Okay, I think it's fine. So we need now to check the bending side to be sure that the length is fine. And you see the bending is there, so it's pretty good. Yeah, clearly. Okay, that's fine. And now the mobility from Malleus is fine. Okay? Alright, that's it. So it was a short procedure because the causal failure was pretty easy to deal with. It's the best situation, of course, because it's like it's a revision, but it's associated with higher success rate when the Incus is intact compared to eroded Incus. So that's really good. And it's okay, fine. It's not always complex when doing revision, so it's pretty good, thanks.